Okay, let's see if I can get a second. I'll load. Well, let's just look at the CTs first then. And then open these. Okay, well that kind of didn't work, but that's fine. So we'll just go through one at a time. So this was a woman who is 50 years old, who came in with severe dyspnea and shortness of breath. We've seen a bunch of these cases now, but this is kind of an interesting follow-up. So you can see this, she was transmitted. So this is back in September, and she had was diagnosed on the outside. She was smoking a new e-cigarette. She just started from smoking regular to e-cigarettes and was smoking Max Ice Melon Menthol e-cigarettes. Came in with shortness of breath about a week or so after starting, and has this, what we've seen, this kind of organizing pneumonia pattern where you get, patchy areas of ground glass, striking subpleural sparing. And she was discharged, and she has a ton of chest x-rays, which I will try to. So here she is on her, so she came into the hospital, that was the CT. She progressed, she got worse. They got a good history out of her. They diagnosed her with EVALI, and she got better. She was discharged, and then about 2 months later, she says she, according to the history, wasn't doing anything else, nothing new. Again, hard to know. She comes in again with shortness of breath, and this is her CT 2 months later. And this has the more, I think, now we've seen a lot of cases, the more classic appearance of this. But this is 2 months later, and it's interesting because she, again, claims she wasn't smoking anything else. And you can see she kind of rapidly progressed to, see if I can find a good chest x-ray. I put them all up here. But she rapidly progressed to a kind of a DAD pattern. But I'm missing the, see if I can sort this by date. Here's the one. So this is about 2 days after admission. Here looks more like fulminant DAD, but what's interesting is that they started her on steroids again, and she dramatically got better. So this is about 2 days after initiation of steroids, and you can see that she's a lot better, and then even a few days later, a lot better. And but unfortunately, we have a follow-up CT, and unfortunately, this is from actually today or last night. The ground glass associated with the lung injury is improved, still has that subpleural sparing. Ground glass is better, but now she aspirated and has an aspiration pneumonia. So just a kind of a follow-up. So someone who had an acute instance of EVALI, supposedly was discharged, didn't do anything else, came back with worsening lung. Again, they bronched her, everything was negative infectious-wise. And then we also have this interesting discussion from that some of us have been having regarding, there's been this stuff about oil red stains and what is their significance. We're seeing these oil red stains, and a lot of pathologists saying they don't mean anything. I've been talking to some other pathologists who say, well, some pathologists saying, oh, the oil red stains are positive and lots of lung injury. And this is a case, I don't want to say from where specifically, but someone sent me from a BAL specimen. And when they're saying that it's positive for oil red, they're not saying it's a couple drops like they see in some forms of lung injury. They're saying, it's massive amounts of oil red that's positive. These are all in macrophages, but they say in addition to them being in the macrophages themselves, there's free oil red from the BAL. They're literally sucking out fat globules from the bronch. So, this is the cause of the lung injury. There's been a lot of talk about the vitamin E acetate as the vegetable glycerin and glycerols and all that stuff. The PG, what they call the PG and the VGs, also contain lipids. So, if this is just a sign of injury or the cause of injury, who knows? But it's just interesting because I never really knew what a positive oil red stain looks like, and supposedly this is pretty fulminant. So that was from another. This is another person. This is another patient that came in, a 23-year-old that was vaping marijuana.
Okay, Seth, can you explain to me, is the oil supposed to be acquired from the so is the oil itself red, or does the oil stain red with H&E staining like
No,
that?
it stains red with this specific stain.
Okay.
Called a red oil O stain.
Okay. So, and what's it staining? It's staining. Is it staining some lipid component?
It's staining lipids, yeah, but it's not specifically staining what lipid. It's just staining lipids.
Okay. Okay. Stains lipids.
And these are a lot of this is intracellular because the macrophages have gobbled them up. But some of this stuff is, extracellular. Like these areas over here, this is extracellular. Like this stuff, these little things outside of the cells. So it just shows that there's lipid not only in the macrophages but also within fluid itself. And this is, there is a lot of, and especially these black market, but even in legal stuff, there's a lot of oils in them. Sure. So we don't know if the red oil stain is sequela of just that, or which again is not good to inhale, or if it's a marker or cause of the injury.
May I ask another question about this person that you first presented? Had
Yes.
she gone off the steroids when she came back with a worsening dyspnea 2 months after first?
Yes.
Okay. So maybe they need to taper more slowly.
Yeah. No, I was trying to find. You're trying to get the medical records, but she got better. She was on like a week of steroids. So here I have the chest X-rays actually, and that was someone else. Sorry. Hopefully that can be edited out. But this was her on her most recent admission, and then you can see she kind of got worse, but then immediately got better when they started her on steroids. So this is, here's where she looks quite bad, and then this is literally 2 days later after starting steroids, getting significantly better, and then had the aspiration pneumonia, unfortunately. But yeah, they did stop her steroids, and after, I think, I'm not sure, I have to look at her history, but they didn't get great history. But she was not on steroids when she came in.
It's also sometimes worth to remember that red oil O may also be positive with endogenous phospholipidosis.
It can be, yes.
Amiodarone therapy. So
no,
the fat doesn't have to come from the outside.
No, it can, and usually you can see it from drugs, but usually the endogenous is secondary to bronchial obstruction. So usually you see that in people who have tumors or other things that obstruct the bronchi and thus kind of impair normal flow, or people who have like severe bronchiectasis who have impaired normal airflow. But most commonly the pathologists see it.
Yeah.
I'm sorry?
But amiodarone itself can produce an endogenous phospholipidosis.
Yeah. No, there's certain drugs. Yes, absolutely.
Obstruction, and it can be positive with oil red O.
Yes. No, an oil red O is, can be seen with lots of things. This patient wasn't on amio, and there's, yes, amio and some other toxins can, without a doubt. But, they're seeing it in all these, obviously, the 29 patients they had positive ELO stains, but, or had positive red O stains. But the imaging that we see does not look like a lipoid pneumonia. That's the other thing. So at least none of us have seen a case that looks like a typical lipoid pneumonia. Let's see, what case I don't remember. Oh, this is a really fascinating case. See if I can get these two to load at the same time, which may not be possible. Let's see. Get your guys, because we see this a fair amount, and this is the first case I've seen the progression. So how often have we seen, or now this is a non-smoker, this is a young kid, and he has these, comes in, has this stuff, right? We see this from time and time again. Bilateral, this weird subpleural cystic stuff. There's no fibrosis, airways there's no bronchiectasis, there's no rear articulation, just this cystic stuff. Has it anteriorly as well. This guy has a very bad case of, you can look from the esophagus, of scleroderma. Okay, according to our clinicians, what like the worst skin findings they've seen. So here's this patient has a cough, and then this is him about a year later, where you're starting to see where these cystic spaces are collapsing down. There's increased consolidation around them. And still though, right? I mean, yeah, we have some mild airway, but really the airways aren't significantly dilated. But you can see how we see some bizarre, what we call honeycombing. I don't know. If you had this de novo, would you call it honeycombing? We talk about this all the time. I mean, it stacks up pleural cysts. I think a lot of people would, even though there's no volume loss. And in these, a lot of patients with collagen vascular diseases, they talk about a straight edge sign and other signs. And the question is, you know, pathologically, they biopsy these patients. They still have UIP, but imaging wise, a lot of times it looks very different. They have large honeycombs, bizarre looking cysts. And, you know, the question is, where does that stuff start as? And does it start as more cystic lung, some form of cystic destruction that then starts to collapse down? And maybe that's why the cysts we see in a lot of these cases tend to be bigger. A lot of people talk about these larger honeycomb cysts in some of these patients. I don't know. I'd be interested to hear your guys' thoughts about this. You can see there's volume loss starting to happen here with the displacement of the fissure. This is the first case I've really seen that nicely displayed over time.
So Seth,
I love this case.
So Seth, I saw a case. Oh, go ahead, David.
No, you're first, John.
I would say I saw a case of I can't remember if it was myositis or not, but it was a connective tissue disease with an NSIP pattern, but it had the cysts, and the cysts were only in areas of other abnormalities. It wasn't like emphysema or other areas of cystic disease. It was sort of like your second time point, but it was a pretty typical NSIP, and that had the subpleural sparing. It was ground glass, but I've not seen one progress, but I've seen several patients with connective tissue disease who seem to get these cystic spaces.
Yes, absolutely.
Areas of what you would call NSIP. And I don't know why that is, because unless it's something with the autoantibodies are damaging lung, and it's almost like a form of emphysema, because it looks
it
like
isn't. You look at this. I mean, this is a lobule. Normal architecture going through it. It looks like emphysema to me.
It's not a collapse,
but it's a lot of this on path is LIP, and some of these spaces, because we've had a lot of these that go to transplant. And you're right, Seth. There's no volume loss. There's no traction, but it does, like, it's an easy mimic for honeycombing.
Yeah, no, of course. And I think, you know, with our criteria, we're subpleural cystic stuff, call it honeycombing, even in the
except there's little, you know, but then you can argue there's really not much in terms of reticulation or traction.
Well, you could say, so the answer is I agree with you, and I wouldn't call it typical. Yeah. We're supposed to, but I mean, you could say, well, this is classic reticulation over here. I agree. There's no volume loss, but to me, this
on the older one, there's not much reticulation. Yeah, I agree.
Even on the newer one, there's no volume loss. I mean, you can see look at this airway between the cystic change. I mean, that's normal, or highlighted. Maybe it's a little bit too distal, but I mean, this is a normal looking airway here. So it's and we see this all the time, and I would love pathologically to get it at this point in time on the left. So where does this start versus where does when we get it, it's scarred down lung, and everything that's end stage scarred down lung is read out as IPF or NSIP. But what does it really start as? And that's kind of the interesting question. And the answer is, I don't know, but just an interesting one to see the progression on. And then
that's really interesting. One thing that's maybe useful is when you see the strange cystic things, don't use the word honeycombing, because honeycombing refers to a particular pathogenesis that has to do with airway remodeling. It's perhaps likely that these cystic spaces have a different pathogenesis from what we call honeycombing. And what it is, we don't know. We just don't see it very often. But I think you've shown a case once of a person with SLE that had that. And I would just call them non-honeycombing cystic spaces.
No, and when I see that, I would not personally call that honeycombing, but I think in other case, I think most people would. I mean, they would see that and they say, oh, it's subpleural cystic change. You know, it's got to be honeycombing. And I think that's, you know, and unfortunately, you know, we do this for a living every day. You know, we are able to tease out some of the nuances, but you know, I think most people, or a lot of people, I would assume if they saw that, they would just say, oh, it's, you know, lower lobe subpleural, that's probably what it is. And then it gets confusing, because I guarantee if you biopsy that spot now, that's what the pathology would show, because it's just scarred down long. And he's like, oh, this is UIP. But so,
Seth, we had some discussions about similar cases like this a few years ago, and you know, we were throwing around terms like bubbly lung rather than honeycomb lung, and then it fits into some of the cases that Jonathan Chung is calling exuberant honeycombing, meaning you get these really big spaces, but they often have very thin walls. There's just not that much scarring. It's mostly sort of confluent big cysts, and you just don't have the scar component. We did have path on a case like that here, and our pathologist said that this is really an emphysematous space, and he said there's no fibrosis in the wall here. This is not honeycombing, but you know, you're right. These tend to get rounded off into honeycombing. But Jonathan Chung has emphasized the you know, the large size of these things, the exuberance, and the cases that we were calling bubbly lung a few years ago are pseudo honeycombing, also part of the same spectrum that you're showing today. But this is the most pristine emphysematous finding that I've ever seen in this, because at the point of your initial scan, there's just no scarring in the walls at all. Those walls are imperceptible.
Yeah. No, it just looks like just standard emphysema.
Not to belabor this, but I think if you have a skilled lung pathologist and they had context, they wouldn't be fooled by this, because they wouldn't describe this as honeycombing. It would be cystic spaces. I'd like to venture that those cystic spaces are probably not lined by respiratory epithelium, but an astute pathologist would recognize that these spaces have not developed as a sequel of progressive airway remodeling.
Yeah, but if they see scarring, they can call it one of two things, right? They can either call it NSIP or UIP. They're pretty much, that's all they can call it. So, I mean, I agree at this point, maybe not, but in 2 years, I'd be curious to see what this looked like. They're going to see scarring here. I mean, there's no doubt. And then what do they call it? They have A or B.
I think that a really good lung pathologist would simply describe the findings and then not necessarily feel compelled to put a diagnostic term to it, but would try to get more information and context.
Yeah. No, it's interesting, and but I'll just, for the sake of time, go to the my last case. So this was a guy, youngish guy, 40s, 50s, very healthy, marathon runner, got sick acutely, had this abnormality. Let's see, does it? Okay, good. It just says man. So this is a male who presented very healthy, came in with this. This was biopsied, and you can see it was read by a very good pulmonary pathologist who said that it was just organizing pneumonia, an early DAD. And you can see the imaging pattern, and yeah, this looks like organizing pneumonia and DAD. Take your pick. I would probably say DAD, fibrotic phase, but there's always organizing pneumonia there. So they treat him with steroids, gets better. Still has abnormality, probably has some degree of permanent scarring from that injury. Some of that may get better. We've seen this a million times. Now, unfortunately, I will send it to you. They didn't all anonymize. I have 15 CTs showing this progression over time. So he was pretty okay. His little ground glassy, you know, peribronchiolar stuff waxed and waned, pretty much got better. But then he got sick again, came in, and then I think everyone in the world would call this DAD, or at least all of us would call this DAD. And this was new from the prior study. Like, his other stuff got better, but still had some underlying fibrotic change. And this is years later. So this is, the first studies are 2013. This is now 2016. And now here we are. I have another study that was 3 or 4 months after this. and unfortunately didn't anonymize. So we're talking, instead of a year later, a few months later, that looked exactly to this. This was his pre-transplant study. And then the question is, what would you call this? And the answer is, well, I think everyone would call this honeycombing. It is honeycombing. I don't think anyone would disagree with this. But it's amazing that this is another case where we have a guy who every collagen and vascular disease panel is negative, every ANA, everything they've run. And he went from basically being normal to OP, recurrent OP, for some unknown cause. Maybe he has some IPAT that we don't know. And then went to explant, and his explant is, typical UIP. So here's another guy who has open lung biopsy after some sort of insult that's OP, kind of waxing and waning symptoms for many years, another acute lung injury, and then goes into fulminant UIP and is labeled IPF. And that's the, so just another one of those cases that shows this progression. And I have, again, other cases in between showing this develop, but I think, again, I'm pretty convinced that all this is due to lung injury and how it responds and how it heals and how bad it is. And just a cool case, I think. I was very excited to see that, to get 12 years of imaging on this guy.
Yeah.
It's almost like the UIP and NSIP patterns we talk about are sort of the end point of a variety of insults.
Yes.
Plenty of organizing pneumonia go on to NSIP, and then you look at that series from Vancouver where they showed progressive NSIP starts mimicking UIP, which
absolutely.
It still looks different, but it has a lot of the features. I think it's just sort of as bad as it gets.
Yeah, and I think, the cases that are more mild OP-ish stuff, a lot of those go to NSIP, and we know that GAD is intimately associated with UIP, because all patterns of UIP, whether it's HP, I have cases of Hermansky-Pudlak, obviously IPF, develop, acute lung injuries, acute exacerbations, which are DAD. So we know there's some association. And on the other hand, acute exacerbations, i.e. DAD itself, is really, really uncommon in cases of biopsy-proven NSIP. There's a paper out there from many years ago saying 5% of cases of NSIP go to have acute exacerbations, but the issue was that with only like 25% of their cases had actually biopsy that they were calling NSIP. They were just saying it looked like NSIP, and they developed acute exacerbations, which were DAD, and thus had that literature, which I just don't agree with. So I agree. This is all varying forms and severities of lung injury and healing. And I'm 100% convinced of that, but,
cool.
I know others are not.
Thank you, Seth.
Yeah.
All right, who'd like to go next?
I have one acute case, Jeff.
All right.
So I'd like to show you a case of a leukemic who was neutropenic for therapy of his leukemia. This is pre-transplant. And this is his baseline radiograph before he got sick. And on the left is the radiograph when he began to be symptomatic, and he has this fairly compact consolidation. I think this man was on voriconazole as prophylaxis against aspergillus. And here's what his his lateral view looks like, with a very nice spine sign, with the lung opacity adding opacity to the spine. So around the time of the abnormal chest radiograph, now on your left, he had a CT scan. This is the day after, and you can see that this is a fairly compact pneumonia, fairly spherical, and especially in the setting of somebody who's on prophylaxis against aspergillus sort of drops in probability as an explanation for a compact pneumonia that looks fungal. This thing came up fairly fast. It wasn't there 10 days before, and now it's fairly compact, and it's got a little bit of laciness here. It looks as if it's trying to form a bird's nest, but it's pretty shabby rim here, not a very well composed bird's nest here. But just wait a few days, and here's a repeat CT now a couple of days later, and now we have one of the world's nicest bird's nest manifestations here, with this very dense rind around a lacy center. And so since this was confined to lower lobe, he actually underwent lobectomy. And so he's had this whole thing removed, and his chest radiograph after that has been pretty clear so far. So this is a classic bird's nest manifestation of that strongly suggests mucor. This was a zygomycete. This was zygomyces, I think, microsporus or something like that. So this was a zygomycete. It was indeed a mucor, and this is one of the world's nicest bird's nests. So a rapidly developing roundish pneumonia, mucor is on the list. Aspergillus first, but if a person's been prophylaxed, it increases the probability that it's not Aspergillus, although Aspergillus can break through. It promotes things like mucor, and also in the right setting, Legionella magdatii. That can give you a round pneumonia that progresses faster even than mucor can progress. So those were all possibilities that were raised on the basis of the first CT, and then the second CT with a classic bird's nest pointed it strongly to mucor. They did identify this Rhizopus species, and he got lobectomy. He's doing well so far.
Yeah.
Excellent case.
Yeah. Okay, so that's the only one I had time to queue up so far, Jeff. So we'll go there.
Howard or Travis?
Jeff, I can go have a few quick ones.
Okay.
Jeff, I've got nothing this week.
Okay. Well, we got plenty of people, so we'll be good. I got enough to fill in if we need. I think
I got a couple.
Cool. We'll fill the whole hour.
You guys hear me?
Yep.
So this is a chest radiograph of a patient who was just admitted for a motorcycle accident. And there's one abnormality here that becomes relevant on a CT of the chest that I read a few weeks later for this patient. So I'll just show this one and we'll come back to the x-ray. So this patient was admitted and he stayed in the hospital for several weeks because he had a bunch of other injuries outside of the chest. But several weeks later, while he was still in the hospital, they got this chest CT because he had a acute drop in his hematocrit overnight. So this was the workup for that. And I was reading this chest CT. I was looking for reasons to explain the drop in the hematocrit. So I didn't really see anything new on this one compared to the other follow-ups that he'd had in the hospital. So I didn't really appreciate anything except for the only finding I saw was this swelling in the left shoulder here. You'd see there's swelling in the left shoulder, and then the other thing that I'm looking for on these kind of studies is active extravasation. So there's this serpiginous high density stuff around the shoulder. So this is actually active extravasation into his shoulder joint, or active hemarthrosis. So then I was wondering why he would have that 3 weeks after he was already admitted. So you go back to his initial chest radiograph, is a dislocated anterior dislocation of his left shoulder, and this is his CT when he got admitted. You can see that, and he has the Hill-Sachs deformity. So what actually happened is this abnormality was identified when he came in, and they reduced the shoulder, but then he developed a DVT during his hospital stay. So presumably it was a hemarthrosis from anticoagulation for while he's in the hospital, and then that explains the active hemarthrosis.
Wow. Can you show us that CT again of the shoulder?
Yeah.
With the contrast?
1 second. Let me go back to. So it's actually like similar to an arthrogram. The contrast is just kind of trapped in the shoulder capsule, in the synovial capsule. And if you like right here, I thought I could see that some of these lines communicating with vessels.
Gosh, that's strange.
And then I'm assuming this stuff here is just hemorrhage, old hemorrhage, but then there's active And I'm not sure if this was entirely the explanation for his. I'm not sure how much blood loss you can get into a joint. I'm not sure if that was the explanation, but that was the only change I saw compared to the other studies.
Oh, that's a good pickup. That's pretty odd.
Yeah, I'd never seen that before. And we'll show another case. It's kind of a fun case. So there's no relevant history on this patient. It's just an abnormality we'd never seen before. But so everything looks normal. And as you scroll down, we see this abnormal soft tissue here, and it looks like it's following the contour of the pericardium. As you go more inferiorly, it seems like it has the exact same attenuation, and it looks contiguous with the liver.
Mm-hmm.
So this is liver that has somehow gotten into the pericardial space, and we'd never seen that before. So I did a quick literature search. I only saw 2 case reports of it from the 1990s, and they were in some obscure. They were in pediatric literature, and they didn't really have a good explanation for it. But then we dug deeper in the patient's chart, and we saw that he had a history at some point. He had some remote history of a pericardial window. So presumably he has a defect in his diaphragm, which allows the liver to herniate up, and then through this pericardial defect, it can get into
Peter,
the
that
pericardial.
looks awfully familiar. Is that a case that I saw 8 years ago?
You might have. So I'm showing I have 2 CTs of it. One was from, you might have seen it before when you were here. That was from 2017, and it's exactly the same. We read this one.
Yeah, I think this guy goes way back.
I remember you showing this case a long time ago.
Yeah.
Oh,
Or a case that looked identical or very similar.
I know. It even has the exact same morphology of the liver.
Uh-huh. Oh, okay. So yeah, I guess he came back for another CT earlier this year. We saw it, and it hadn't changed at all. I looked back at his older CTs. I included 2 CTs, one from 2017 because it had contrast.
Speaking of pericardial stuff, there's a famous or infamous case here in San Francisco of a patient that underwent an interventional procedure and ended up with a hepatico-pericardial fistula. So they had like bile in their pericardial space from a procedure. So, but I don't know if I can find those images. That's an older one, but that's the only other thing I can think of that's similar to this.
Mm-hmm.
So guys, it turns
There
out
are congenital hernias of the diaphragm that will connect with the pericardial space. So, this seems to be a pretty broad base of liver going in there, and looks very smooth. I'm not sure that this is from surgery. I mean, I think this is potentially congenital.
So David, it turns out that the central tendon of the diaphragm is fused to the parietal pericardium.
Yes.
Level. So, because I think I don't know if I showed it, but we had a case of a intrapericardial liver from a trauma case where the diaphragm ruptured, and it because when it tears, it just takes the pericardium with it because it really becomes one piece of tissue, and so that's where most of them occur. And I guess if you have either a congenital absence of the pericardium or a surgical defect in that location, they're both going to go.
That's right. When I first saw this, I was thinking, you're going to tell us there was a history of blunt trauma, and this was unrecognized rupture of the central tendon.
Can we show the coronal again, Peter? Did you show the coronal?
Yeah.
It's got such a broad base.
Here's the waist right there. It's going in.
And you can see the defect in the diaphragm just above the stomach.
It's so clean looking. I think that this is probably congenital.
Okay. Yeah, I mean, I'm not sure. I did see that they had a pericardial window. That's the only thing I could find in the chart. But
Yeah, but it usually those higher up.
Dichotomy.
Yeah.
could be.
Hospital Tower, 9T Tower North,
Matt,
Roman 942.
I have one more case. Just
Hospital Tower,
you guys can excuse me for a
9T
second.
Tower North, Roma
announcement.
942, Code Med, Hospital Tower, 9T Tower North, Roma 942.
If you
Okay,
smell
so-
smoke, it's time to call.
So this is my last case. This is a case which was shown to me last week by my new colleague Karen Dill. So this is a middle-aged patient, developed crushing acute onset chest pain, and also had positive troponins. So this was his coronary CTA out of the ER, and it was essentially a normal CTA, except for one abnormality here, subtle in the at the ostium of the left main. And you can see some on the axial, some mild narrowing there, and you can look at it on the short axis. If we zoom in, this is a pretty good view right there. If we zoom in on this, so this is the section that we're talking about. There's this circumferential, it's noisy, but you can see the circumferential concentric soft tissue around the ostium, and then the actual vessel caliber kind of looks ovoid and looks compressed. So our diagnosis here was a type of SCAD with a intramural hematoma, and we don't. I mean, there isn't good enough spatial resolution here to see if there's or isn't an intimal flap, which is hard to see on a coronary CTA.
So I
You
think
can see the narrowing on-
last week, right?
Yeah, except this one is more proximal, I think, than the one left from last week.
Mhm.
Yeah, I still don't know how to differentiate those from, it's really for me onset of symptoms, but if this patient was asymptomatic, would you call it some sort of vasculitis? Would you consider vascular? I still don't know how to differentiate, because I've tried to measure the ROI of the fluid and the false lumen on these, and I don't get blood attenuation, and I believe this is a SCAD. I just don't know how, someone says, well, why isn't it vasculitis? And I'm like, I don't know.
In my opinion, it's hard to measure. There's just too much noise because there's only
Yeah, no, that's what I'm saying. Yeah.
pixels around here. So if you put an ROI, you're going to pick up just a lot of noise with really high.
I understand. I'm just saying I don't know how you differentiate them from vascular. If they come with acute chest pain, have a troponin bump, then it's going to be a SCAD. But if it's an outpatient who has a finding, I don't know how you differentiate. What is the history on this person? Did they come in with
Acute chest pain? Acute chest pain.
Yeah, that's okay. That's a good case.
The FFR was negative. CT-FFR was negative. They did a follow-up. That's all I have.
All right,
Thanks,
awesome.
guys.
Thanks. Brian, you doing cases?
Yeah.
Okay.
Great. Can you guys see my screen?
Good.
Excellent. So this lady is a 70-year-old who came to me labeled as UIP, IPF. But, in reviewing the images, I thought it looked more like it was mostly just emphysema. Kind of similar to Seth's case, but unfortunately, a few years later down the line, you see in the apices what's clearly emphysema with extensive paraseptal, and then these are kind of thick section images, but you can see there's quite a bit of central lobular emphysema as well. And then inferiorly, someone had previously called these honeycombs. But when I started looking at individual airways, they look pretty normal in caliber. They're about the same size as the adjacent pulmonary arteries. Here's the coronal view. I see the fissures look like they're in normal position. No clear attraction bronchiectasis. So I wanted to run it by you guys, see what you think.
Can you show the sagittal again?
Yeah, sure. I can pull up the sag.
Looks like a nice straight edge sign.
Yeah, and the macroscopic, the giant honeycomb cyst with
I think this is collagen vascular disease, all
rheumatoid arthritis, maybe.
Yeah, there's no history of collagen vascular disease in this person. Yeah.
Yep.
Because
bubbly lung. This is emphysema. This is not fibrosis. It's really
Okay.
emphysema, not honeycombing.
Yeah, that's what I thought too. You know, and it's funny. They did this kind of interesting protocol where they did a like kind of a live acquisition of the expiratory phase, and you can see here when they're breathing in and out, or breathing out rather, there's no change in the density of those cystic spaces at the bases. Here's a similar similar part higher up, and again, no change in any of those cystic spaces. She had been treated for the past few years on antifibrotics, and you know, came back for a repeat exam 4 years later, and I think things look exactly unchanged. So I told them I thought this was all just emphysema at the bases, definitely at the.
But it's not emphysema. I mean, I agree these are big bubbly spaces, but they're walls to these. This isn't. I'm not arguing that it's not a UIP, but yeah, this just screams of connective tissue disease.
Oh, interesting.
Right? Don't you guys agree?
Yes.
Yeah.
Because it had that nice straight edge that David pointed out, and then the giant cystic spaces. Because as Travis said, these have walls, and paraseptal emphysema is going to form a single row at best, and these are too big. And up top, you had stacks of them.
Yeah,
it also has it has involvement in the anterior upper lobe, which I think was also mentioned in that Jonathan
sign. Yeah, it's got all three of those signs.
Yeah.
Yeah.
So you guys think, even though you know, some of these are like 5 centimeters large, that there's no signs of like traction bronchiectasis or fissural or retraction, that they're just giant honeycomb cysts from.
That's the term used, but I don't think it's the same thing. I don't know what those are from. They're probably true cysts from some obstructive process.
Yeah, they're big cystic spaces. It's not honeycombing. I agree. They're large, and there's many things going against a UIP IPF diagnosis in this woman.
So what honeycombing should require is that you have not just holes in the lung, but you've got fibrous capsules around those holes, and there's no fibrous capsule here, so we don't have the fibrotic component. So these are cysts or kinds of emphysematous spaces. You know, a lot of these really were aligned. The upper lung stuff fits pretty well for paraseptal emphysema. Then I think you get some inner layers involved too. It's not just all at the periphery, but in the upper lungs, it's doing a very good job of being peripheral and looking just like paraseptal emphysema.
Yeah, I think the question was more so was going on inferiorly, and yeah. Cool. So another case.
Yeah, and this is just really quick. Like, this is one of the problems I have with the 2018 ATS designation, and I think Fleischner wording is similar, but they say honeycombing with or without peripheral traction bronchiectasis or bronchiectasis for UIP, which I disagree with. And as David just said, you need to have fibrosis there.
Yeah, you do need to have fibrosis. Yeah, that's why I thought these were not honeycombs, because I didn't see much in the way of fibrosis. Okay, cool. So the next case, similar story. So this is a CT from 2008, and the story on this guy, he quit smoking about 10 years earlier and has a history of autoimmune hemolytic anemia. And what was striking to me is all these lower predominant peribronchovascular cysts. There might be a little bit of ground glass. It's hard to tell. No clear reticulation. He had this funny family history where both his mother and sister were diagnosed with quote-unquote sarcoid. Unclear how that diagnosis was made. And then he came back. This is now 2019, so 11 years later, and like really progression. And now I think some areas are starting to look almost honeycomb-like. There's a little bit of traction bronchiectasis, but definitely a progression of the cystic spaces. I thought, since the honeycombing wasn't that predominant and the extensive cysts, that it was unlikely to be UIP, IPF. I thought maybe LIP, He had quit smoking. It wasn't that. And then I was thinking, what about COPA syndrome? I haven't seen many of those, but I know that cysts can be present in those as well. So whatever you guys think. What do you guys think?
I like your LIP.
I see. I like this for DIP. So DIP is, I mean, A, it's dramatically lower lobe predominant, and DIP is not a benign entity, and it doesn't always resolve after smoking cessation. There are many reports and cases of it actually, and it's they say about 25%, even with smoking cessation, progress to a fibrotic process. And I've seen a lot of cases through where Brad Path stuff from the JPC, because there's a hell of a lot of smokers in the military that have this, what looks like DIP, that progress to this end stage fibrosis kind of picture, and they undergo transplant, and the transplant shows DIP with NSIP, that when they, take it out, it's actually NSIP. But, it's presumed the DIP can lead to, I always thought that it just, if you stop smoking, got better and that was it. It's kind of like HP. Even when you remove the antigen, some people, that the inflammation and still progress to fibrosis, the same thing can happen. So, I think to me, it's DIP.
These cysts are so big, though. I agree with what you said, and I think that's a very reasonable thing. But when you just see the first case, those cysts they look a lot like the LIP cysts we see. They're perivascular. They have vessels running along their walls. They're a little bit more variable, and they have that striking basal predominance.
Yeah,
I don't know. I'm just.
It'd be good to have Pat. It'd be interesting to see which one this is.
I agree with that.
Patients with
How old is this patient?
Also progress with
70
fibrosis.
Yeah. Your mention of COPA syndrome, those patients almost all present in their teens or 20s at latest.
Yeah. Okay. Yeah, I was just including that because of the weird family history.
They're much smaller cysts, and they can, one of the cases I've shown, like the first time they did a biopsy when the patient was a teenager, they thought it was all follicular bronchiolitis.
So, Brian, what did you say his smoking history was at the beginning? He's a heavy smoker?
Well, I think he had like a 30-pack year history, but prior to the exam in 2008, he had quit. So the bottom exam, this was from 2008. And then this is 2019, and so he had been. So he has at least a decade of smoking cessation. I think probably closer to 15 years. Let me. So yeah, it's been a while. He quit smoking in 2005. So 3 years prior to this CT, 14 years prior to this CT.
I think that drops DIP, which I think is otherwise, a really good suggestion. The other thing I'd worry about.
No, but DIP can still progress after smoking cessation. I'll pull up some cases I have if I have time, but anyways.
Okay, but the other thing is that I would also consider for basal predominant cysts is amyloidosis.
Oh, that's a good thought. Cool. And then the last case I have is kind of is a fun one. No diagnostic dilemma here. So this is a 20-something or 30-something-year-old man with osteosarcoma of the left lower extremity. And I've seen a few of these cases with sarcomas where they have these kind of ill-defined branching nodules. And when you follow them on serial imaging, so this is December of 2018. And then he came back in March of 2019 and then September of 2019. And what you see is just this slow progression of these nodules. Make sure that the annotations don't include the patient's name. So in particular, so we'd kind of seen this one earlier, and that one grew. They ended up doing a mastectomy on that one. But you can see here, there's not much really brewing in the right lower lobe, the medial right lower lobe. But then when he came back in, this is September 2019, so only 9 months later, he now has this nodule, which I told them about. I said, this is very concerning for embolic tumor. And when you looked at he had local recurrence in the femur as well. Unfortunately, they took him for mastectomy of the left lower lobe anyway. And I've seen a few of these cases now where they do these metastasectomies, but I really feel like we're kind of missing. We're seeing only the tip of the iceberg on imaging, because it requires, for us to see them on CT, it requires that pulmonary artery to become enlarged enough to the point where it's much bigger than the adjacent pulmonary arteries. So we're really insensitive for that, for tumor emboli.
Okay.
Yeah, I think that intravascular tumor growth can obviously be hard to discern. Your best chance is if you see one is to, yeah, you see it there, their tubular opacities, is to use MIPS, relatively thin MIPS, and examine the rest of the lungs really carefully, looking for little vessels that are not normal caliber tubes, but that are expanded like that one.
Yeah, so when I read this back in September, I went back and I looked, and he had like 3 or 4 exams between September 2019 and December of 2018. And when you look at this this artery in particular, it just very, very slowly started growing. You know, but I've seen a lot of these where they start off like that. They start off looking essentially normal. You know, you get a little bit of motion, you really can't see much. You know, maybe I think this is it, probably in December 2018. Hard to call anything there. And then just little tiny dots appear, ever so slightly. And, you know, then it really begs the question, you know, like if that's present there, that's a big one, that's obvious, you know, where else could they be in the lungs?
Yeah, it's hard. And not only MIPS, but it's a good idea to look at sagittal and coronal MIPS. Sometimes it's easier to discern the small tubular opacities. Yeah.
Yeah, cool. Well, those are my cases.
Thank you. Howard, there's probably time for one case if you'd like.
Okay, I'll show one case. Let's see, I'll pick one that's most interesting. Okay, how about this one? So this is a bedside radiograph here, and it's the first one we have, and the finding is pretty obvious, which is the opaque left hemithorax with displacement of the heart and mediastinum slightly rightward. And then if you don't have any information, but then you see there's gas in the abdomen, you're thinking, okay, at least abdominal surgery. And the question is, what surgery? Can we tie in this with the findings of surgery, which is air or at least gas in the upper abdomen? And sure enough, we can. This person had a transhiatal esophagectomy for a cancer, and this is very soon after surgery. So with that context, chylothorax is way up there, and this is a chylothorax. So they drained some of the fluid. It's obviously really large. Here I'll just bring in the op report and show you that in spite of the fact that the person had a duct ligation via surgery, via a VATS, it didn't work. Perhaps it was really difficult. And I'll just show you the op report from that. But that wasn't successful. The chyle leak persisted. So he went on to lymphangiography. So this is the usual lymphangiography where they start off by injecting contrasting nodes. Then they identify the cisterna chyli. These are not in order. So somewhere around here is the cannulation of cisterna chyli, the small microcatheter guide wire, microcatheter threaded up. And that's the beginning of the microcatheter. Then you'll see that they confirm the presence of a leak. And then, sorry, these are not in order. Once they identified the leak, they then embolize it, or they try to plug the leak with, initially they put in embolization coils, and then they deploy glue to progressively occlude the thoracic duct from the level of the leak back towards the cisterna chyli. So these are not in order, but it shows successful obliteration of the thoracic duct via a combination of a coil or two and glue. So chylothorax, big chylothorax, not successfully fixed with a thoracic duct ligation. All right, Jeff.
Thanks. All right, guys. Thanks for all the great cases.
Thank you.
Thanks, guys.